Hi, everybody. Dr. Becker here. I'm really excited because I get the opportunity to be with you this week to discuss palliative care. This is my niche, if you will. This is where I've been practicing now the last couple of years, is specifically to palliative and hospice care. I'm going to go ahead and use the PowerPoints that accompany your textbook, as you can see here, for your evidence-based geriatric nursing protocols for best practice, so that we have a point to start and kind of add some of my own parts into it. I would love if I could someday teach an elective, maybe a 1 credit over a semester for those of you that want to know palliative care, because I could talk about this topic easily for 12 or 15 hours. However, we have just this week to talk about it, so let's dive in and we'll go through at least what the book has as a general guide, and I'll throw in my own information along with it. I do like the definition that the book is talking about for palliative care. There are many definitions of palliative care in terms of being an identified, defined idea that words and labels have been attached to. This is relatively new in terms of a specialty. So 40 years ago, we probably didn't see as much palliative care by definition like it looks like today. The main component when you talk about palliative care that sets it apart of all other specialties is that this is the area of care where, by definition, we are caring for the patient and their family. When you talk about what is a cardiologist, when you talk about what is wound care, when you talk about what is prosthetic care, when you talk about what is cancer care, specifically those are things that are directed purely on the patient. Palliative care is defined always including the patient and their family, all definitions across the country, across specialties. That is what sets palliative care apart. And the reason that it's patient and family is because we believe in holistically caring for the patient and bringing all aspects of their life to the surface, put all the cards on the table, and review where they're at in their life to support them the best we can of all parts of their life. So social, physical, emotional, where they're at intellectually, spiritually, and then the physically, right? All together. And so we know that in order to really care for someone spiritually and emotionally and intellectually, and socially, you have to talk about what their life looks like with their support team. And when we can support the support, that means it's more support for the patient. So oftentimes, when you are dealing with people that have a serious illness, by definition, it comes with burdens of disease. By definition, a serious illness means that you oftentimes are sick. And when sick people are sick, they need help. They need their support. And typically, hopefully, they have support. So you have the daughter, the mother, the spouse, the friend from church. Somebody tends to be your main support person or people that can help you go to the doctor, that can help you keep your medicine straight, that can help do those things that sick people need help with. So if we can treat the patient and their family and their loved ones, their support, we can do much better overall in caring for the patient as a whole. So palliative care is defined as, at least by the government, patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. I like this definition. It's very short and sweet. Some of the different organizations around palliative care, their wordage gets to be a bit much, so this is pretty straight and to the point. Anticipating, preventing, and treating suffering. Okay? When we go down in this line, it talks about specific characteristics that underpin palliative care. It says services are appropriate at any stage of a serious illness. So for me, if I could redo this definition, I would say palliative care as patients at any stage of a serious illness and their patients who are at any stage of a serious illness and their family. We provide patient family-centered care or something along those lines, right? I would want to throw in the fact that this needs to be into a serious illness. And we talk about a couple of other underpinning things is that we really promote patient autonomy. And how does one get autonomy to make an informed decision of what is right for them comes to access of information. I oftentimes will tell you, I feel like a translator, honestly. I take what every other ologist is telling a patient and their family, and I come back full circle and I go through it all again in layman's terms over again. And I feel like I'm interpreting so that people that are lay people that are not medically savvy, and even people that are medically savvy, when it's your loved one, your brain just works differently. That I have the opportunity to translate that that information in a way that allows them to actually digest it and understand it. Okay? So we promote patient autonomy because we are saying to you, here's all the information in a way that you can understand. And I will sit here with you until you tell me you understand it. And if that takes 30 minutes or 3 hours, I'm here for you and your family. Right? So if the patient's a man and he's 70 and his wife of 50 years is with him, I'm going to sit with them and make sure that they understand together. The people that are his support system are in the mix as well. And I will stay there with them until they feel like they have received the information and they've had time to process it, that they feel well informed. And then the decisions that they make on how they want their care to be, what they want their life to look like, X, Y, Z, those are driven by their ability to make those decisions because they're well informed. A couple other specific things that you find in palliative care consistently across the country is also that it's an interdisciplinary team. So I am not, as the medical provider on my team, I am not the most qualified to do a spiritual assessment by any means. So on my team, we always have a chaplain. Now, the chaplains are people that they don't have to be of a religion denomination to be able to help process a spiritual assessment for a patient. They are a crucial part of the team. So typically on the team, you often have provider, nursing, social work, and chaplain as the main four. Then depending on how big of a program you have or what resources you have in your area, other parts of the palliative care team can be like a clinical psychologist, a pharmacist, a dietitian, sometimes like a physical therapist. Some of those ancillary support things could be people, if they have the ability to bring it into their interdisciplinary team. The circle of care includes the patient, their families, the palliative and the non-palliative providers. And we work as the team to make sure we are communicating between everybody. And I almost become like a case manager in some ways for a patient. I can think of right now a patient that I'm working with that's had a fairly profound stroke. And he has a sister that is his power of attorney because he's impaired in his ability to communicate with me. And he has a multitude of health problems, so he has a lot of ologists and a lot of things going on, unfortunately. And so what I honestly do is I will work with him and with the sister, and I'll say, what are your appointments coming up? Oh, in 3 months, that's when you see, nephrology, cardiology, and oncology. Okay, how about I see you 3 days after that? Let's make an appointment. And literally I do that to say, let's regroup. Let me go over all their information again, and I will be able to walk through this with you guys to make sure we understand what the game plan is and to talk about things. And then at that appointment, I could say, let's anticipate some of the questions that you do want to have answered and write them down for them. So it is a circle of care, and that we oftentimes are the train conductor to make sure that circle remains communicating with other people. The services can be available in conjunction with or independent of whether or not they want curative or life-prolonging treatments, and I'll talk about that in a second. And the goals of care for patients and families are supported, and congruency is ensured throughout the course of the illness, during the dying process, and after death. So that's also a little different. And I'll show you an image here in a moment that ties this all together. The one other thing I'm going to point out here, when we are talking about anticipating, preventing, and treating suffering, when we are talking about quality of life, if we were to stop and think of quality of life, pain, suffering, these are not clear-cut, easy to discuss topics. They don't even have a consistent definition that people will commonly agree upon. These are abstract, nebulous, philosophical, moral, and ethical based ideas that can be vastly different across age groups, races, religions. Everybody can look at it differently. When I talk about quality of life, I can't define that for my patient or their family. I don't have a set of clinical practice guidelines that say, if you measure the size of their great toe and the color of their hair, they would be category A for their quality of life. It doesn't work that way. So I have to get to know the patient and their family in the best way that I can, often in a short amount of time, to start to help them identify, how do you view quality of life? For some people, it is very clear to them, I would never want to live like this. For many people, there is this idea, at least, some kind of line in the sand that they can start to think, I'm not going past that. But for other people, they have never thought about it. It just honestly never crossed their mind. Many people, for some reason, just didn't really have to ever deal with death. They weren't around with the death of their grandparents or their parents or what have you. Like, they honestly just never thought about it. And then we have people that are scared of it, and so they don't want to talk about it. So just when we start to think about what does palliative care do, it is a tough practice. If for nothing else, then it's a constantly moving target, right? If I am a nephrologist, I can get data numbers and I can tell you, you have chronic kidney disease stage 3B. And I have at least then a general target from which I can look towards to, shoot my arrow. When I say you have a chronic you have a life-threatening or a serious illness, and I'm going to help you with your quality of life because you have a good quality of life or you have a poor quality of life. I don't get to define that. I don't have any objective data points. I cannot define people's quality of life, and neither will you guys. And when you are out in practice as a provider, you have to remember, it is not you, it is them. They get to define quality of life. They get to define what is suffering. You will come across people that 100% in your mind to you are living in a way that you would think to yourself, anybody with a rational mind would define this as poor quality of life. Anybody would look at this and say this person is suffering. And yet they want to do more treatment, or they want whatever, or they are willing to do X, Y, and Z. And to me, I'm looking at them going, are you nuts? Look at how much you're suffering, right? And we have to put that aside as providers because it's not about us, it's about them. And I'm telling you that people will define pain, suffering, and quality of life in 1,000 different ways that will blow your mind. So when you talk about palliative care, when you consult palliative care, when you as a provider think palliative care, it is not about you and your definitions. And I'll talk a little bit more about that later on, but I wanted to plug that in there. As we talk about this topic, I can't give you clinical practice guidelines, evidence-based practice that are clear, cut, follow the formula type of things. Now, we do have data, we have surveys, we have qualitative data, we have things that we know we ought to do in a certain way to guide us a little bit, but you'll hear what I'm saying in a little bit when you can understand. It's a very nebulous, abstract idea, and it's a constantly moving target. If there was one image that I would want to share with you guys, it's this. This is my favorite illustration that to me really will help people understand palliative care. A couple things to point out. Here on this side over here, there's a lot of medicine that can happen before a diagnosis that palliative care does not have a part of. Breast cancer screenings, colonoscopies, like this isn't where I'm meeting people, okay? Once someone has achieved a diagnosis of a serious illness, let's give the example of heart disease. So someone has had a massive heart attack, okay? Now they have that diagnosis, they've had their STEMI, and right away, this is the kind of zero. So on the y-axis here, we're talking there. But over here along this course, this is the time from diagnosis on. And so they've come in, they've been diagnosed with heart disease, and they've had their STEMI. They can very much have aggressive, active disease-treated or directed treatment. We are trying to prolong your life and fix the problem, treat the problem. But we know that coronary artery disease that was bad enough to cause a STEMI is a big, life-threatening, serious problem. So they've gone to the cath lab, they've gotten their stents, they're on goal-directed medical therapy, they're on their aspirin and their Plavix, and they're on their diet, and they've met the diabetes coordinator, and now they're going to go to cardiac rehab. They are doing all those things, and we found out that they had a massive heart attack. They had a little bit of a reduction in their EF. I mean, they were very ill with this and in the hospital, and now they're feeling better, those kind of things. Even early after diagnosis, you can see palliative care has a place, right? Because it depends on the details of the patient. If this patient is 50 years old and has a strong support system and is a very active, otherwise healthy person, maybe I don't meet them as soon as I'm going to meet the 82-year-old that had this NSTEMI, because they also have had prostate cancer for 5 years. They've also got chronic kidney disease and poorly controlled diabetes, right? They are a seriously ill person. So even though they want to remain aggressive, is the word we like to use, or very active in curative treatment, palliative care, I can still begin to sprinkle in and meet them. Early in a disease process here, a lot of what this looks like, from this section here, what that's going to look like is a lot of education. A lot of, I want to talk about the future. Look, you've had this massive heart attack. The disease and the atherosclerosis in your arteries is not going to go away. We don't have a magic pill to reverse the damage that's been done to your heart. We know with doing X, Y, and Z, you will have better outcomes than somebody who doesn't do X, Y, and Z. But at the end of the day, you now have heart disease that's known. It's not going to go away. And so when we think about that, now this is a new layer of complexity we've added onto your health. Let's start talking about what the future could look like. Whether that's 1 year, 5 years, 10 years down the road, the data tells us with your age and everything else you have going on, you are likely to experience, again, problems related to your heart disease. And because of that, let's talk about it. What would be considered suffering for you? How much would you want to go through in your healthcare? So often in the beginning, those are the kind of conversations we have. This is also the time where I feel I'm an interpreter. Like I said, bringing all of the ologists together, meeting with the family, meeting with the patient and the family together, and talking through all of this. Well, this is what this means. Now, this is what the cancer doctor was trying to tell you. Because you're on androgen deprivation therapy and now you have heart disease, this is what they mean. Well, so that's what the cardiologist meant. Oh, well, this is what that means. And we kind of put it all together in simplistic ways to translate it into a language in a way that they can understand. But as the course of these serious diseases go on, we start to run out of good options, right? The damage that has been done to that person's microvascular system since having years of poorly controlled diabetes and their smoking and their family history, right? Eventually they're going to start to have more trouble with their heart, more heart disease, more whatever. And so we start to run out of options. And so as you see that, about the time that we're running out of options, the diseases continue to progress. You're now older, sicker, frailer, most times in elderly patients. Then now we start to focus more on reducing the burden of symptoms and suffering and less on trying to fix the problem, until we do eventually often meet a point when we no longer have disease-directed treatment that is going to be effective to offer anymore. And when that point in time comes, then curative measures stop and palliative care is the whole piece. And then we talk about the red is end-of-life care, which is hospice. Okay? All of hospice falls under palliative care. So everybody on hospice is essentially on palliative care, but not everybody on palliative care over here is on hospice. Okay? So palliative care is the big umbrella, if you will, that covers, and we do a lot of things. And one part of that umbrella is end-of-life care. And then ultimately, the patient dies. But because we are focused on and we have cared for both the patient and their family, part of palliative care includes this piece, which is bereavement. Bereavement usually is defined as 13 months after their illness, or their death. And the reason for that is we know that the 1-year anniversary of someone's death is the hardest. And so instead of just saying we're only going to follow people for 1 year, we go to 13 months, so that in hopes that we help them through that anniversary of their loved one's death. And then part of the hospice will kind of fade away. But part of the support is that we will continue to help you as you grieve and you're in your bereavement period. So this to me is a great illustration to show you this part. Palliative care can happen concurrently with a curative intent. Where this comes into the biggest play, I would say in my experience, is with cancer. Okay? So if you have been diagnosed, you have a 50-year-old female patient who's been diagnosed with an aggressive form of a terrible form of breast cancer, the prognosis is not great. The numbers aren't great. Can that woman be cured of her breast cancer? Yes. But this is that kind of situation where not a lot of people get that outcome. Unfortunately, this aggressive type, even though you're technically only stage 3 right now, eventually a large majority of these women are going to move on and find out they're stage 4. Okay, so in that scenario, it makes total sense that we begin to support. We are having conversations, we are supporting, we're talking about the what ifs, while they are actively getting chemo and treatment, and they are trying to completely get rid of this cancer, and I can still be a part of their team. Their whole goal at 50 years old could be to eradicate this cancer and never have it come back and live to be 80, and I am still part of their team because they are dealing with a serious illness with a great degree of burden, whether that's social, physical, emotional, intellectual, financial, all the things. The burden of that disease is great, and it impacts the patient and their support system. And so by the definition, when we talk about what palliative care was, even though they are seeking aggressive curative, they want to get rid of the cancer. Their goal is not to die. Their goal is to live to be 80. We are still an appropriate part of their care. And people just, even in healthcare, I get this all the time. Well, I didn't consult palliative care because, well, she doesn't want to die. She doesn't want hospice. Why would I consult palliative care? And I just want to wring my hair and say, because we don't wait till they're dying to help them. My hope would be we could walk alongside them to the cure. That would be great. So when you're thinking about palliative care in the future, remember it can be done concurrently alongside of curative care. That is what ties in that the care is through the dying process and after death, which is bereavement. I already kind of mentioned on this. In general, the difference between palliative care and hospice is the curative intent behind where they're at in their journey. So yes, when people are still actively treating their disease to some degree or another, they are typically under palliative care. But once people reach a stage when they are no longer actively seeking curative active treatment of their disease, and we think that they're in the last stages of life, they transition into hospice care. So again, hospice is part of palliative care. Everybody on hospice is under palliative care. But not everybody under palliative care means they're on hospice. And this is what is so hard for people. The family freaks out, the patient freaks out, everybody freaks out because they think if they're on palliative care, they're dying right now today. And they are distinct things. If the program and the system works right, hopefully a very large majority of people that ever enroll in hospice will have been on palliative care services prior to their hospice status. Now, sometimes that doesn't happen. If they're 50 years old and they had a massive heart attack and now their outcome is really poor, they're acutely ill in the ICU and we just don't know if they're even going to survive, they probably weren't on palliative care first. But in terms of people dealing with lifelong, chronic, progressive, serious diseases, heart failure, COPD, chronic kidney disease, cancer, ideally, they would be part of palliative care long before the hospice part of palliative comes into play. Down to the technicalities by Medicare, which is the most governing body upon which hospice is guided. So they set the tone for everything related to hospice, just like they do in private insurances. So everybody follows CMS guidelines for hospice. So per the Medicare hospice benefit, they have to have a terminal diagnosis, which means they have to have 3 criteria. They have to have a life-limiting diagnosis, a prognosis of 6 months or less, and the desire to forego curative treatment. Why is it important to tease out these 3 different criteria? I know many people are thinking, well, duh, they all go together. The fact of the matter is it's very important to outline that there's these 3 distinct parts, because I have run into many a situation where people have decided to forego treatment. So without treatment, they are likely to live 6 months or less. However, the definition of life-limiting diagnosis is a little gray. Example, 60-year-old female who has dealt with chronic genetic kidney disease her whole life, and she's now approaching stage 4, or she is now in stage 4 kidney disease. She's also got another congenital issue that has made her in and out of the hospital all the time. She's a diabetic, she's disabled, she can't work. Her quality of life has been poor for a really long time, and now she's lost her vision. Okay, so she's a chronically very ill, frail person. What is her prognosis? What is her quality of life? What happens in the situation where that person decides, I don't want to live like this anymore. So I am choosing to stop taking my curative treatments. I'm no longer taking my kidney medicine. I'm not going to take my insulin. I'm not on dialysis yet, but I'm no longer going to be actively managing my care. I am stepping away from all curative attempts, and it is what it is, and I'm just ready to go. I'm ready to die. What does one do with that situation? Because if we go off of our previous slide and kind of think of it that way, you would argue that that poor woman has not actually exhausted all of her healthcare options. So I don't have a nephrologist that says, yeah, it's dialysis now or she's going to die. No, the nephrologist is saying, I think she's got 2 or 3 more years until she's looking at dialysis. We've done a really good job of being able to keep it far away. But in order to do that, she's got to take all these medicines and the binders and whatever. And she has to have good control of her diabetes, because otherwise it'll wreak heck on her kidneys, right? And the endocrinologist is saying, we've gotten decent control, but like she's on a continuous glucose monitor. She has to check all the time. She's been in and out. She has to follow this extremely strict diet. Okay. Why am I bringing this example up? Because it's important to understand, by definition, does she have a life-limiting diagnosis? She doesn't have a cancer with a poor prognosis. She doesn't have an EF of 5%. She doesn't have a creatinine approaching 7 with a bicarb of 12 and a potassium of 6, right? She has life-limiting, possibly, diseases. She's full of diseases that at any point in time, we wouldn't be surprised if she passed away in the next month. But in that moment in time, does she have a terminal diagnosis? I could go off on that topic, but we're not. Then we get into autonomy, ethics, morality. Do people have a right just to quit their treatments? Is that the same as committing suicide? Would that be considered physician-assisted death? These things can really get into a lot of down the rabbit hole. The other part about hospice care, especially when it's regarding Medicare, is that you have to have conditions of participation. And that is meant that everybody has to follow these guidelines to promote consistency and quality. The 4 categories of hospice care are available. So CMS recognizes home care, continuous care, inpatient care, and respite care. Hospice is a benefit model of care for patients with end-stage illness who want to forego curative treatment. The challenge is what to do for patients diagnosed with life-limiting illnesses who either do not qualify for hospice, or they do, but they don't want to give up their curative therapies, or people will be like, I'm never going on hospice because I'm not a quitter. Okay. The way that they say palliative care is an effective solution for these patients, I hate. And if I could call and write to these people and tell them, please remove this sentence from your slides, I would. I mean, I could, but I don't think they're going to listen to me. I don't like that. This is giving this a really weird version of that, because remember, they're already under palliative care, essentially. So that's dumb. Palliative care is delivered to patients diagnosed with a serious illness for whom cure is not possible. However, the illness could have trajectory of days to years. So the dosing of palliative care may vary depending on the illness and its stage of severity. What they're trying to say is essentially what I showed you in the previous image, was that you can have small amounts of palliative care early when you're having larger amounts of curative intent. This is a decent slide, I think. Remember that palliative care as a whole, we're focusing on quality of life and reducing the burden of suffering. And so we can do that at the same time that we are giving life-sustaining treatments or curative treatments. And this could be a longer period of time than is possible under the hospice benefit. So remember, you can only be under hospice label when you're under that certain set of criteria. What we're really trying to say is that palliative care then, technically, if you're not a hospice, palliative care is under its own reimbursement type picture. Okay. I do think this is a decent comparison. People have to choose to be on hospice, and it is still covered under Medicare Part A or Medicaid or some commercial insurances. So the current state of palliative care: in 2014, the IOM released Dying in America, Improving Quality and Honoring Individual Preferences Near End of Life. And they worked to report on 5 areas of quality needed to achieve healthcare improvements and move care upstream to patients with serious illness rather than focusing on end-of-life care. So the 5 areas were delivery of person-centered and family-focused care, increasing clinician-patient communication and increasing the amount of advanced care planning we're doing, professional education in palliative care, policies and payments for palliative care, and then public education and engagement in palliative care were the 5 areas of focus from 2014. I do agree that nurses have one of the most prominent roles in all of the palliative care models and are often the one that are at the forefront of clinical care, especially in palliative care. So I like that they say that palliative care is synergistic with nursing, because what they're saying is it models and runs parallel to nursing anyway. The idea of treating the patient holistically, caring for their family, promoting autonomy, trying to reduce suffering. I mean, it sounds like nursing 101. So the NCP is the National Consensus Project for Quality Palliative Care, and they did their clinical practice guidelines for quality palliative care, and that was first published in 2004. The guidelines have been updated 3 different times. That will continue to reflect healthcare reform and help reflect the most current recent literature and advancements. The most recent guidelines do focus from neonates to the very old adults, providing a framework for the future of palliative care, serving as a manual or blueprint to create new programs, to guide developing programs, and to set high expectations for excellence. I love my NCP clinical practice guidelines. They're kind of like our Bible. They're very effective in helping standardize programs across the country. Especially when you think about palliative care can be in a community, rural, critical access hospital, or it could be in a major metropolitan, tertiary care center. And so having some standardization across that is very important. There are the 8 domains of palliative care that are listed here. These are some of the other parts of the quality portion when we look at palliative care. I will let you read through these on this slide on your own. This is in your reading as well. Measuring What Matters is a joint program between the American Academy of Hospice and Palliative Medicine and the Hospice and Palliative Nurse Association. So the AAHPM is the medical side of hospice and palliative care, and the HPNA is the nursing side of it as well. HPNA also helps with certifications for chaplaincy and social workers. These are the 2 working together groups that are working to promote further measurement in the field, as listed there. We now have options for specialty and certification with palliative care. Like for me, I am certified now as an advanced practice palliative care nurse. The options for palliative care go to chaplaincy, medicine, nursing, social work, and then hospital-based programs as well can be certified as hospice excellency. The one area on here that they don't really talk about is there really isn't a great option for specialty certification for PAs. It just isn't in existence yet. But there are a lot of PAs working in palliative care, so it's an area of growth that needs to happen. This is about the palliative care education. I want to point this out here, LNEC training. If you've heard of LNEC, it is this. End-of-Life Nursing Education Consortium is LNEC, and they have a lovely program that helps certify nurses and provide the education for certification for end-of-life care. When I was first in school many moons ago, palliative care was not included in curriculums. Medicine, it was not part of curriculums. This changed around 2010 to 2015. So they started instituting that there should be competencies in education in undergraduate nursing students, And now that has also trickled over into the medicine world. So all medicine students and residencies and that are including palliative care as part of their education and curriculum. So it's really been beefed up from the education side of things. Okay. Outcomes of palliative care. Here's the deal. Money talks, right? So if you are a major medical healthcare system, we've talked about the business of healthcare and all these things. At the end of the day, you have to balance your books, right? Nobody's going to be able to stay in business if it costs way more to provide the service than you get paid for the service. It's just at its most simple form. The fact of the matter is, palliative care, when you look at the cost of a palliative care program, in the first look, when you just look like the basics at the top, the summary, palliative care costs a hospital or a healthcare system money. Palliative care does not directly get money. Meaning, if I and my team bill for our services, we are not going to be able to actually be paid to recoup the price of what it costs to have us on board. Okay? So at the basic, if you look at, I make $100 an hour, which I don't. But let's say I made $105 an hour. And if I'm working a 40-hour week, I am never going to bill for enough to cover the cost of me having my job. Right? I'm not going to get $4,000 a week plus paid back to my company that can help cover the expense of having my team. However, everybody has a palliative care team because the outcomes and the cost benefit savings comes tangled up in the details on the back end. And so because of that, we can justify our need. And the bean counters, if you will, or the money team, the financial team, the money people, they can see at the back end, at the end of the year, at the end of 5 years, we have actually saved indirectly, not as easy to see, money for the patient and the healthcare system. So the evidence shows that we have improved the patient quality of life and satisfaction, which a lot of our billing now in America is tied into satisfaction scores. We are improving pain and symptom management, and we're reducing the cost of care. And that is buried in that indirect way, but I see it every day. A couple of different ways, right? Here's one of the main ways. When we as America, started looking, in the last 20, 30, 40 years of Medicare, where are we spending the most money? And you guys know the answer to this. We are not spending 80% of Medicare dollars keeping people healthy at the front end. We're not spending that money on screening and health and preventative medicine and initiatives to keep America healthy and prevent disease. No. We spend the largest amount of our Medicare dollars at the end of life. When the cat, the cow is already out of the barn. The person already has 18 diseases. And the majority of that money was being spent in the last 2 weeks of their life, if not the last 2 months. So we were taking people that were 85 years old with terribly managed diseases and putting them in the ICU and spending $500,000 on their care when every provider that walked in the room 100% anticipated they were going to die and not make it. So one would ask, why would you do that? Why would you put them through 10 days in an ICU at an extremely expensive level of care when everybody anticipates they're at the end of their life? So if I get to meet people 5 years earlier, right? Because the cow's already out of the barn, they already have all these diseases, but I meet them when they're first diagnosed with their heart failure and now renal disease and they're 80. And I start talking about educating and anticipating and knowing and talking about it and setting standards for them and identifying how sick they would be willing to be. And we talk about all these things when we're not in crisis. The families had a chance to digest it. The patients had a chance to digest it. Now they're a DNR. Now they have realistic expectations. And often when they do come to nearing the end of their life, I can have them on hospice. And we can allow them to die without going through 10 days in an ICU. And that saves everybody money as well. I don't do my job to save everybody oodles of money. That's just a positive, unintended side effect of what I do. I do my job to give people improved quality of life. Palliative care does occur across all healthcare settings in all different areas. We now have different non-palliative care groups, or the academies of the professional groups outside of palliative care, who now are incorporating into their society definitions of when you ought to consider palliative care based on their diseases. So what this one's talking about is that the NCCN, the National Comprehensive Cancer Network, now says as part of their clinical practice guidelines, you ought to consider providing palliative care for patients with uncontrolled symptoms, patients with moderate to severe distress, serious comorbid and physical conditions, life expectancy less than 6 months, and patients that are concerned about the course of the disease, even when they're only expressed by family. Like the American Academy of Cardiologists have their own definitions of when you ought to consider palliative care for heart failure, for heart disease. This is awesome because it's helping the clinicians stop to think, oh, they're saying I ought to consider having palliative care involved. This is a good thing. These are some of the tenets of palliative care. A different view of what we were talking about. These are great. Let's walk through them quickly. Palliative care is patient and family-centered. There is a comprehensive care team with continuity across the healthcare setting, inpatient, outpatient, in the hospital, out of the hospital, at the specialist, at home, doesn't matter. Earlier introduction of primary palliative care concepts should begin at diagnosis of a serious or life-threatening illness by the primary team. What they're talking about here is that we as medical providers, we have taken the term palliative care and more accurately labeled it as either primary or secondary, meaning everybody can do primary palliative care. If you are the family practice nurse practitioner in Timbuktu, middle of America, you can do the primary components of palliative care. Education, bringing in the family, having goals of care discussion, some of those basic ideas of how to begin to support from a palliative care perspective should and is able to be done by anybody that's a provider. When they need more than that basic top level, then you need the secondary palliative care experts, which is what I do. So that's what they're talking about. The goal of palliative care is the relief of physical, psychological, emotional, and spiritual suffering. If provided early, it allows patients to achieve quality of life while living with their serious illness. Palliative care may be offered concurrent. We talked about that. At advanced illness and end-of-life care, peace and dignity are preserved during the dying process and after death. Palliative care team members have clinical and communication expertise achieved through education, training, and specialties, certifications. Palliative care is interdisciplinary and collaborative communication between patients and families, and then the palliative care team is essential to providing this program. Equitable access to quality requires a commitment to building primary palliative care skills across all disciplines. All right, this is talking about having hospital-based palliative care. This is primarily what I do, but I also do outpatient as well. Clinical responsibilities after consultation vary within the different hospitals. Hospital-based models are often the easiest to implement, but they typically by nature are crisis-oriented, so they may need 24/7 access, which not everybody can do. The critical access hospital's not going to have a 24/7 palliative care team on board. That's just not going to even be possible, right? The other benefits of possible hospital-based palliative care is that we often can have lower costs, earlier discharge, and highest satisfaction of patients, and then we can do better pain management and symptom management. Then we also have the need to have office-based palliative care as well. I'm moving through these kind of quickly. Remember that you still need to be interdisciplinary even if you're office-based. These are a lot of things that you guys don't need to worry about. Palliative care in long-term care settings is very appropriate. It is still not well developed at all and is a huge area of need across the country. And that wraps up at least those slides, which is helpful. Get through those. So if you've made it to this far, we've gotten through all of the technical aspects of the PowerPoints associated with your evidence-based practice book. A couple of things again to reiterate is please remember that everybody on hospice is under the umbrella of palliative care, that not everybody on palliative care is on hospice. Ideally, palliative care should start early. Often, one of the biggest questions I get from inpatient, outpatient, all of the above, from all the providers that I run into is this: when do I know to consult palliative care? I was thinking about it, and then I'm like, well, my answer to anybody is, for sure, at the very least, the moment you thought of that question. If you as a provider even have that pop into your mind, should I consider palliative care? The fact that something about the situation, the scenario, the symptoms, something about that even made your mind pop over to think the idea of palliative care, it is probably meaning it's a good time to consult us. Because you have seen something as the provider that has made you think they're frail. There's a possibility this isn't going to go well. They're suffering. The family dynamics are poor. They're so unrealistic about expectations despite me really trying my best. X, Y, and Z. They're getting lost in the system. There's something that has happened to cue your mind to even think that thought. So I tell people, if you think to ask that, it is probably meaning it's time to consult us. Even if it's very early and we don't see them again for 2 years, consult them sooner rather than later. So that's one of the first questions I always get is, how do you know when to consult? The next question I tend to get a lot about, at least in the adult community, again, we're in adult practice, I'm not talking pediatrics, but in the adult realm, one of the next main questions I get is, do palliative care providers do pain management? And the answer to that is, it depends. It depends on what your team does and doesn't do. So across the country, different palliative care providers have different bandwidths. They have great support, or they have no support. They can only take on so much, etc. So if you were in a really good palliative care team that has great resources, plenty of staff, X, Y, and Z, oftentimes they will do pain management. The problem is that there is a difference between chronic pain management and pain management when you're getting close to the end of life. And so a lot of people don't do true pain management. And the reason for that is often bandwidth. There's just not enough time to take on that. But also, there are clinical pain teams, and that is their thing. So for me, in my life, I do not do chronic pain management unless it's associated with end-of-life care or very close to being terminal diseases. So what do I mean by that? And they have to be mainly comfort focused, not just pain, but also relief of suffering because of a serious, almost life-ending disease state. And so that is not the same thing as managing their chronic back pain that they've had forever. So I have written for morphine or Ativan for COPD patients before they're on hospice, yes, because they needed improvement of their symptomology. I do not take on treating a 70-year-old's chronic low back pain and neuropathy just because I saw them for their heart failure. There are people that are part of pain teams that have their own interdisciplinary approach. They have their clinical pharmacists, their psychiatrists, their whole team, the PT, the OT, all the resources. Interventional radiology, pain management's what they do all day, every day. They can do methadone, buprenorphine, all the things that take a little skill and time and energy and expertise on. That resource exists. So most palliative care people, in my experience, agree that we don't take on pain unless it's symptom management nearing the end of life. Me personally, that is how we function where I work. The next question I get a lot is, should I consult palliative care because the patient needs to be a DNR? And this comes back to the primary versus secondary palliative idea. The ideal situation would be everybody can be primary palliative care. A family practice doctor should be able to have the beginnings of conversation because they're receiving this in training. They're learning how to have hard conversations. They're doing this already to feel empowered and feel competent to do conversations. So, in the moment, in an ideal situation, most of the DNRs would come from long-standing relationships with either your primary care or your ologist, right? A beautiful world would be that you've gone to see Dr. McGillicuddy, for the last 9 years. You trust him. He knows you and your family. And now he can say to people, I think it's time we visit about code status. Let me explain what this means. I'm worried about you. Your health is not the best. Have you thought about this? X, Y, and Z. And if it becomes apparent that they haven't, that they need a ton of more information and time, or there's family dynamics and all the things, and now they realize it's not a fairly straightforward thing, then yes, you should consult palliative care. But anybody is capable of getting a patient a DNR. Other question I get quite a bit. How do you get people to become a DNR when you know that's what they need, but they're resistant to do it? I get this all the time. In essence, this is what people are asking me. Maybe they word it a little differently, but that's what they want to know. And what I would say to this is, my definition of palliative care is what I agreed with on one of those first slides. My job is to walk alongside a patient and their family to help improve their quality of life and help decrease the burden of their disease and to decrease pain and suffering of the person as a whole, right? Is any part of that definition, did you hear me say, it is also my job to browbeat somebody into a DNR? No. People have the right to make their own decisions in America, even if we all feel it's the wrong one. So people consult me. Sarah, well, he needs to be at the DNR at the very least. It's a full code. Oh my gosh. Consult palliative care. I don't walk in there and say, I'm not leaving this room until you have agreed to become a DNR. That doesn't work that way. I can counsel people and say, I think it is reasonable for someone in your situation to pick a DNR. I don't think that would be unreasonable by any means, because I am worried about your health for X, Y, and Z. And I say to people, so I want you to have all the information so you can make an informed decision that is right for you, where you are at in this point in your life and your journey. And I tell people, I can have my opinion, but I'm not walking your shoes. You are. You're the driver of this bus. So whatever it is that you pick today, I will help support the best I can. Whether that's a thing I would do or not do, doesn't matter. I will support your decision. I'm here for you and your family. So the answer to that is you cannot make somebody become a DNR. You just cannot do it. I'm going to end the video here. We've made it to an hour. And thank you for listening. And please, as always, feel free to always reach out to me if you ever have any questions about the content or just things you need a palliative ear to listen to. Thanks, guys.